Okay, hi, Paul Slatkus. Good news broadcast. We're going to talk about a disease that unfortunately I'm familiar with since my mother had it, Parkinson. And April is Parkinson Disease Awareness Month. And thank God for that, to let more people know about it. It's not such a good situation. New way, however, good news here, a new way to help make days with Parkinson's disease more predictable. Okay, so this is interesting. And we have an expert here, Dr. Stuart Isaacson, who's the director of Parkinson's Disease and Movement Disorders Center. Good morning, Doctor. Hi, how are you?
Good, thanks. Thanks for having me on to talk about Parkinson's and some new treatment options.
Great. Where is your facility?
Oh, our center is in Florida, in Boca Raton, Florida, and we have a large clinic, but also a very active research center trying to find new treatments for Parkinson's disease, as well as hopefully a cure for the disease.
Okay, and I'm sure, unfortunately, you probably have an active Parkinson disease community. You have a lot of old people. I know a lot about Boca. I'm a New Yorker, so we know about Boca Raton. So, including my aunt, and then this one and that one. So, um, well, tell us about what is Parkinson. I worked on the Brain series on PBS many years ago. So somehow the brain, I think, has an effect of why you do have Parkinson's disease. Well, what is Parkinson's disease? Let's start right there.
Sure. Well, Parkinson's disease is a common disorder. It's the second most common neurodegenerative disorder of aging. It's over 1 million people in the United States have Parkinson's disease. We don't know what causes Parkinson's, although maybe 20 or 25% of people have a gene that can cause it. We don't have a cure yet, but I think a lot of research gives us hope for a cure in the coming years, sooner than later, we hope. But we know that the symptoms of Parkinson's, both movement symptoms and non-movement symptoms, occur because of changes in brain chemicals. And in particular, loss of a chemical in the brain called dopamine. When we lose dopamine, it affects movement. And we try to improve dopamine in the brain by over 24 medications we've had approved over the years, and then new ones recently as well.
So are these medications orally, put into our bodies?
Yeah, so in trying to improve dopamine in the brain, over 50 years ago, it was discovered that L-DOPA, levodopa, can be taken as a pill and get through the stomach and into the bloodstream and into the brain, and it becomes dopamine in the brain. It's converted into dopamine and improves movement. It's called a miracle drug for that reason, but it works so well in the first few years. But the problems that many of our patients face is that after a few years of working so well and so consistently, it's taking a few doses a day, that after a few years, the benefit from each dose begins to last only a few hours. And then another dose has to be taken, and another dose, and another dose. And patients may never know when they swallow one of these pills how quickly it will work, how long it will last, and when the next dose has to be taken. And they get these ups and downs. When the medication's working, they can move better, but some get these extra involuntary dyskinesia movements. And then after a few hours, the medicine's not giving benefit, and the movement problems come back, trouble walking or balance or shaking in the hand that we call tremor, slowness, stiffness, getting in and out of a car or out of a chair, being able to work or go to dinner or exercise. So we've really tried to think about how we can combine different medications to get a more even benefit throughout the waking day.
So how do we do that? I mean,
Also, we've long.
we have a new pill that
Yeah.
has it, or you take different pills during the day. How do you go about that?
So a couple of ways we can take doses closer and closer together, but it can get hard to remember to take these pills so close together every 2 or 3 hours. And even in doing so, there's still these ups and downs. We have some longer acting extended release pills that can last for a few more hours. But we're really excited about a new option that was recently approved by the FDA called a NAPCO. And On behalf of Supernus, we'll work with Supernus to study this new option. It's been available in Europe for over 30 years. And over the past 10 years, we've studied it here in the United States to see how it can help people living with Parkinson's in the US. We found ANAPGO to be effective, to be safe. And some people can have side effects like nausea or dizziness, sleepiness, skin reactions, but overall it demonstrates tolerability. And we found that it can take people who take all these medications, but only half the day they're having good benefit. And just by adding ANAPGO on, they can make it over 3/4 of the day good benefit. But it's not a pill. ANAPGO is a wearable device that patients can put on each morning. And it gives the medication that works like dopamine in the brain. It gives it just beneath the skin where it's absorbed into the bloodstream, goes directly to the brain, and improves movement and keeps that movement improved throughout the waking day. They put it on in the morning, they take it off at night. So it can really be a very, very, I think, a game changer for a lot of people who live with these ups and downs to make things more even and avoid those ups and downs.
It seems that patches and things like this are become more popular over the years.
Mm.
But how does it literally get into your? Is it the blood system? Where's it going once it's attached to you?
Yeah. So it's interesting because, one way, a common way to get medication in is through a pill that's swallowed and absorbed in the gut into the bloodstream. Another way is to put a patch on the skin and it goes through the skin. But many medications can't go through the skin. So ANAPGO has this, looks like a patch. It's about the size of a quarter. It's right on the skin. But on the underside of the patch is a tiny little plastic Teflon-like catheter just about 9 millimeters. And it goes right through the skin. It's put on with just like a little button, and it goes right through the skin, and it delivers the medicine just beneath the dermis, just beneath the skin, and there's blood vessels there that absorb the medication as it goes in continuously over the 16 waking hours, and it goes directly into the blood vessels, circulates straight to the brain, gets into the brain. It doesn't have to be converted. It's already active. It works like dopamine. It actually looks like dopamine and works like dopamine in the brain to improve movement. So for medications that have these ups and downs when you swallow them due to absorption variabilities and metabolism or can't go through the skin, this is another way, this wearable device. It's been used, this type of idea, for diabetes with an insulin pump, and now we've applied it to Parkinson's disease to get this dopamine medications into the brain more evenly.
Wow. And does it go like on the arm, or is there a certain part of your body that's more accessible, let's say?
Yeah, so we studied this clearly, and many people wear it over their stomach, their belly, and some can wear it on their thighs or on their buttocks or over their arms. You can wear it different places because it just goes beneath the skin and gets absorbed. It's not for everyone. People should talk to their doctors and nurses. They should keep track of their symptoms when they're having benefit and when they're not having such good benefit. They can go on the website. There's a website that has information about this and some diaries that people can keep and information about ANAPGO at anapgo.com, onapgo.com, anapgo.com. But it's really something that I think can really help people who may be having some difficulties in getting a good response to the medication over the past couple of years. And just by adding this on to what they're already taking, can have benefit. We saw benefit as early as 1 week after beginning ANAPGO.
Do you see, and thank you and congratulations. This sounds
Mhm.
great. In our future, do you see any opportunities for curing this at a young age when you're born, of detecting that you have this concern? How do you see the future in that you're in this full time, right?
Yeah. Yeah, so it's, I think it's so much progress and research going on. We work with the Michael J. Fox Foundation, other groups. What we've learned is that Parkinson's disease begins 5 or 10 or even 20 years before we make a diagnosis, with things like loss of smell and constipation, low blood pressure, acting out of the dreams. We have new tools to make a more accurate diagnosis earlier, using gene testing, a skin biopsy for a protein that's involved in Parkinson's, brain imaging that looks at dopamine in the brain, so we can make a diagnosis earlier and more accurately. And we know that about 25% of people with Parkinson's may have a gene that causes their Parkinson's that we can test for earlier. And there's about a half a dozen or almost a dozen medications being tested in the US alone that aim to correct those genes. And as we move to a more personalized and precision medicine approach to each person finding out why Parkinson's affects them, we're developing therapies to really target that. So I truly believe we're going to have a cure for Parkinson's, but it may be a different cure for different people with different causes of their Parkinson's.
Let me ask you one last question. I thank you because I know you have a busy schedule here. Hereditary wise, my mother had Parkinson. Is there potential that I will, as a result of hereditary, ways?
Well, things that run in families can run in families. Most Parkinson's is not known to be genetic right now. In large series that have been done in the US and in Europe, about 15% of people in general might have a gene that causes Parkinson's. If there's a family history, then it might rise up to 20 or 25%. So it's still not 100%. But even people who have a gene that might have caused Parkinson's in a parent, having that gene only causes Parkinson's in somewhere between 10 to 30% of people. So even if you get a gene, it may not cause Parkinson's. And we don't know why. We're trying to understand why some people with the gene get Parkinson's, but most don't. So it's a higher risk, but it's not really high compared to that. Most people, even with the family history, even with the gene, don't get Parkinson's. But it's important to be aware of these things and the new advances, because when we do develop a cure for Parkinson's, we want to take that as soon as possible. We want to make that diagnosis as early as possible. So we have a lot of hope for the future.
All right. Well, you're an optimistic man. That's great and positive, and we like that. That's good news. So, what's the website again? Because it'd be wise to take
website is anapgo.com, ONAPGO.com, anapgo.com.
All right, Dr. Isaac. Thank you very much for sharing important information.
Good talking to you.
Take care. Bye-bye.
Bye-bye.